Imagine two different public hospitals. On paper, they look identical. They have the exact same number of beds and the exact same number of staff. But in reality, Hospital A is a specialized hub. The patients coming through the emergency department are dealing with highly complex, life-threatening conditions requiring intensive care and specialists. Hospital C, meanwhile, is a major district hospital. They see a massive volume of patients, but the vast majority of these cases are routine, uncomplicated, and stable. Because the current funding system relies on a global budget based on historical spending patterns and bed capacity, both of these hospitals receive roughly the same amount of money. Counting beds and staff completely fails to measure the intensity of care the clinical teams are actually providing. This system is now running headfirst into a harsh economic reality. National medical inflation is climbing rapidly, currently sitting above the Asia-Pacific average of 10%. Rising costs expose the flaw of the old model. Without a way to accurately measure how much work a hospital is actually doing, the government cannot produce an accurate budget to keep it running. For the clinical staff, this means the grueling complexities they navigate on the wards every single day remain invisible to the people allocating the funds. To secure the resources necessary to survive these rising costs, hospitals need a reliable way to make their invisible workload visible to the system. That is the exact problem a patient classification system called Casemix is designed to solve. Conceptually, Casemix functions as a universal translator. The process begins right at the patient's bedside, relying entirely on the qualitative notes and medical records written by doctors and nurses. Casemix takes that written clinical story and converts it into standardized, quantifiable data units. It bridges the gap between the messy reality of patient care and the rigid structure of administrative databases. Rather than simply recording that a patient was admitted and discharged, the system extracts three highly specific metrics from the case. First, it measures the severity of illness and the clinical complexity of the diagnosis. Second, it calculates the workload intensity required from the staff to manage that patient. And third, it tracks the actual physical resources utilized during the stay, from medications to major procedures. When we apply this logic back to our two identical-looking facilities, the data tells a completely different story. Casemix clearly quantifies that managing the complex, critically ill patients at Hospital A demands drastically more time, skill, and equipment than treating the routine cases at Hospital C. This proves to the decision-makers that funding allocations must be tied to actual clinical effort and patient severity, rather than outdated historical habits. Historically, Malaysian public hospitals used this data mostly to analyze clinical performance and mortality rates, but moving forward, the focus shifts to costing, budgeting, and workforce planning. To get there, the Ministry of Health established a clear roadmap. Step 1, building a foundational data infrastructure across hospitals. Step 2, analyzing real healthcare cases against actual operational costs. Step 3, using that analysis to enact national healthcare financing reform. The immediate milestone on this roadmap is the implementation of a diagnosis-related group reimbursement system, starting with the Medi-Asas pilot in July 2026. Every phase of this national transition relies entirely on the accuracy of the data being tagged into the system today. Casemix provides the vital foundation for modern hospital survival. If clinical documentation is vague or incomplete, the system registers low case complexity. The actual workload goes completely unrecognized, and as a result, it goes underfunded. On the other hand, clear, precise documentation of every diagnosis, complication, and procedure ensures the system has the hard evidence it actually needs to justify providing more vital equipment and more dedicated manpower. By embracing thorough documentation, frontline staff hold the power to secure the budget and the resources their hospital actually deserves.